Welcome to the Birth Journeys podcast. I'm your host, Kelly Hoff, BSN RN. I am a wife, a mother of two, and a nurse specializing in the care of women and newborns. In this podcast, we will share powerful journeys of birth givers with the goals of lifting the veil on the birth experience, healing through sharing, and beginning an open conversation to strengthen trust and promote transparency between birthing people and healthcare providers. Hello. Today I have with me Michelle Powers. Michelle is a certified nurse midwife and the mother of two, and today she is here to share her fertility and birth journey with us. Michelle, welcome and thank you for joining me.
Hi, everyone. Thanks, Kelly, for having me on. As Kelly mentioned, my name is Michelle. I happen to be very privileged to work within the birth field. I'm a certified nurse midwife, which means I have a master's of science in nursing, and I get the privilege to take care of women across the lifespan, which includes gynecology, as well as obstetrics, prenatal care, and of course, doing deliveries within a hospital setting. I am the very honored mom of two boys. My oldest is Nate. He was born in December of 2018. And my youngest is Samuel, and he was born in December of 2022. So he's approaching, I guess he is 5 months now. So a little bit about me and how I very much got to become a mom of two. I was on a perfect journey. I was not one of the lucky friends of ours or patients who got to spontaneously get pregnant. As Kelly mentioned, my infertility journey is one that's pretty expansive. From the get-go, I had the mom when I was a teenager who said, "It's weird that you haven't gotten your period. You're 15. This is strange." Whereas I thought it was great. Who wants that? My friends are miserable. But she took me to our local pediatrician who referred us to Duke University, where I got to know somebody who was very advanced in the field for managing polycystic ovarian syndrome, or PCOS. Now, more and more over the past decade or so, lots more of information has come out about PCOS and its impact on the lives of women across the lifespan and across the age. But most specifically, one of the things that we talk about PCOS most commonly for is infertility, or trouble getting pregnant. The biggest reason that happens is because even though there are many women who have PCOS who maybe get a regular period, and there are those of us who don't, but more importantly is that we do not ovulate. So ovulation is the process by which the body or the ovaries spontaneously release an egg. And if you, as the female partner in a relationship that is planning to get pregnant, the female that is trying to get pregnant, are not releasing eggs, then there is no genetic material to form an embryo or to form a pregnancy. You're missing half. And so although there are more studies, medications, and suggestions out there, a lot of us women with PCOS tend to seek reproductive services or infertility services. Being somebody who lives in the Northern Virginia area, I was very pleased to see that we had a high resource environment and high resource community. So I was able to get evaluated, and it was not easy. We attempted to do some low intervention infertility work first. We tried intrauterine insemination, which is non-surgical. It's where my partner of choice, which happens to be my husband, his genetic material was with a procedure kind of put inside of my body so that an egg and sperm could meet to create an embryo. We tried that about 5 times, all without success. So during that, it took about a year. And even before that, all the testing and some weight loss and some medication attempts. He had visits, all this type of workup. We're probably about 2 years into it and still not pregnant. There's definitely some really low lows during that time, feeling, especially as somebody who has the privilege to work taking care of women who are pregnant. It was really hard to see all these successful birth stories, successful pregnancy stories when I couldn't have one of my own. But through that, with counseling and support from my partner and my village, we eventually decided to make the leap from IUI, or intrauterine insemination, to a procedure called IVF, or in vitro fertilization. This did involve a surgical component. This is where, after medication that I was taking as well as injected, my ovaries on ultrasound demonstrated that I had lots of eggs that were mature. And so with surgery, they took the eggs out of my ovaries and put them into their science lab. And with the genetic material of my choosing from a male partner, which again happened to be my spouse, my husband, they created embryos in their reproductive lab. So this is where they joined the egg and the sperm outside of my body and fed these embryos. And we got daily updates about how the eggs were doing, how the embryos were doing. Statistically, about 50% of the eggs collected die before sperm can be successfully inserted into creating an embryo. So we were lucky enough to follow that statistic, and they harvested 20 eggs from my body, and we ended up getting 10 healthy embryos. That's a pretty normal statistic to get double the eggs and only have so many embryos that are healthy. We are very lucky to feel safe enough in our health history to not need to do further testing on the embryos. And so we froze 9 embryos, and that 10th embryo became our first pregnancy. And I luckily had a very safe and healthy pregnancy. We found that it was more that I didn't release an egg, but my uterus did okay and kept a healthy pregnancy. I did get hypertension with my first, and so I had an induction of labor at 37 weeks. And delivered Nate. That was very exciting, and we loved everything about it. And then with Samuel, or Sammy, our youngest, second time around was a little bit easier, less medications, no surgery. Since we had frozen embryos through our reproductive endocrinologist, our infertility team, we were able to just go on a little bit of medication and tell them our desire or plan of when we'd want to have that embryo put inside of my uterus. And luckily, again, that worked out very successfully. Another healthy pregnancy. This time I had gestational diabetes that I needed insulin to control and hypertension. And so again, I got induced at 37 weeks and had baby Sammy. I did have 2 vaginal deliveries, one with each boy. I did not have any postpartum complications other than just continuing to need medication to manage my blood pressure for about a month postpartum. With Nathaniel, my first, Nate, I had pretty severe postpartum depression. I sought counseling and I got put on a mood stabilizer called Lexapro. I am still on that medication today, and I did continue that medication through the pregnancy with Sammy, and that really did seem to help my postpartum course this past time. I think that's a lot about me. Experience. I feel like that was a lot of information.
Yeah. I want more
life
though.
history.
Let's talk about your births. So you got induced. When did you find out you had the gestational hypertension?
Yes. So with Nate, I was 36 weeks pregnant and didn't feel great. And my husband also happens to be a family nurse practitioner. And so I said, hey, do you have your blood pressure cuff? I don't feel great. I'd like you to take my blood pressure. So he takes it to the manual cuff and it's mildly elevated. And he says, yeah, but I don't think this is the right cuff size for you. And I looked at him and I said, $10 says I get induced in less than a week. In case anybody wants to know how that worked out, I was right. In case anyone's keeping tabs. And so at my 37-week visit, my first blood pressure was elevated and was met criteria. Now, by chance, I happened to be being taken care of by the practice that I worked for as a certified nurse midwife. So I went about seeing my patients on my schedule, and 4 hours later, took my blood pressure again in the office. It was still elevated. And so we decided that for safety, we would call up to labor and delivery and see what they could do. And so I found out at about 37 weeks in one day, because it was a Monday, and my gestational age weeks changed on Sunday. And we were admitted Wednesday evening, and I delivered Friday morning.
Amazing. Just go on and work through that hypertension.
Worked the next day delivering babies, delivered babies, and then, had another half day, came home, installed the car seat, grabbed some Chick-fil-A, and headed in. So.
Awesome.
It's the most classic provider story ever.
Yeah. Are you pregnant and planning a hospital birth? You don't need a birth plan. You need a birth vision. In my opinion, birth plans set you up for failure. Yep, I said it. Hear me out before you turn off this podcast. You may think that by downloading a generic birth plan, it means you're in control. The truth is, it's not that simple. No one can control exactly how their birth will go. There are way too many variables. What every pregnant person wants is to walk into the hospital pregnant and to walk out with a healthy newborn in their arms. The journey in between is the murky part. It's hard to know what issues might come up that need to be addressed. If you focus your energy on a birth vision rather than giving your power to a birth plan, you can empower yourself to make the best choices for you and your baby. That's why you need to get into my Empowered Hospital Birth program. As a labor nurse and mindset coach, I can help guide you through the process of maintaining the calm autonomy that will help you achieve the birth vision you desire. In my Empowered Hospital Birth program, I will help you identify the source of anxiety you have surrounding hospital birth, fill in knowledge gaps to make sure that you are fully informed and confident, learn key phrases so you can better communicate with your medical team, emotionally process your fears so that they don't hold power over you. Go to kellyhoff.com/empowered to book a free 30-minute private birth vision call, where we will identify your top fears and must-haves and gain clarity on exactly how you want to feel in the birth space. That's KELLYHOF.com/empowered. I'm honored to be a part of your birth journey.
So just to clarify on the recommendations, when you have a high blood pressure that is within the range that's not severe range that needs to be treated, right? So
Yep.
you have to have 2 that are 4 hours apart.
Yeah, so the diagnosis of gestational hypertension is you have blood pressure readings, at least 2 of them, 2 data points, where either the top number is greater than or equal to 140, and or the bottom number is greater than or equal to 90. So like a 136 over 92 still rules in, a 144 over 88 still rules in. And the reason that we recommend having 2 at least 4 hours apart or longer, right? So if it was just an office visit and they were seeing you back in like a day or 2, again, that may still rule you in, is because part of gestational hypertension and really part of hypertension in pregnancy is that it can be what we call labile, right? It is not unheard of to have a pressure that is elevated and may be something that we say, oh, this meets a certain criteria we have for potentially a diagnosis, and then have 2 hours of normal, and then all of a sudden have another one. And that's because it's not chronic. It's not something where your body is changing forever. It's being impacted by the pregnancy and the placenta and the gestational age. And it's saying, hey, I'm okay, but I'm not great. And when that starts to happen, the safest recommendation is delivery, because that truly is the cure, right? Now, depending on your gestational age, medication or watch and wait may be a safe alternative. Once you're full term, which is 37 weeks or greater in your pregnancy weeks, at that point, there's only risk, right? And so the recommendation then becomes move towards delivery in a safe manner versus waiting it out.
So then the difference between that gestational hypertension and we need to move now is if you have one of those really severe range, like potential to have a stroke or a seizure range.
Yeah, it's usually more about mom, right? I mean, we know, as any pregnant woman who's even kind of happy about being pregnant, right? I mean, pregnancy is not easy. It is not for the faint of heart. But most of us, at least once we hit a certain point in the pregnancy, say, okay, I am excited about the outcome of this pregnancy, right? I am desiring a healthy outcome of this pregnancy. Once there comes a point where we actually are about mom, right? At this point, although yes, a seizure, a maternal seizure, or the pregnant woman has the seizure or things of that nature could impact baby. Babies actually tend to do okay. They're well protected. It's mom who actually potentially is the greatest risk to her health. And we've come so far to grow a healthy baby. We want that baby to have its mom, right? We want this family intact and complete. And so if we are recommending either an expedited path to delivery, whether that's preterm or full term, or potentially even bypassing an induction due to significant maternal factors and clinical findings that dictate that a 2 to 3 day induction may not be safe for mom's outcomes, and therefore a C-section or a surgical delivery is recommended, that all comes down to maternal health, right? And so when we're talking about that, we're talking about blood pressures that are 160 over 100 or higher. And those tend to be much more consistent. They tend to be, it's not that you go from 160 down to 120, right? You go to 160, like 158. Woo, right? Like it's not the same where you're like, oh, I'm 138 over 98 and then I'm 112. Like, that's gestational. All right, fine. Mild hypertension. Okay. No, when you've got your severe range pressures, there's actually some lab values that tend to dictate that there's been some other potential internal changes to mom's organs. And we're, for better or for worse, we're racing a clock, right? We know that in labor and delivery, in pregnancy even, things can change on a dime, right? We have women who have excellent fetal movement and then don't. We have women who are having no bleeding and they're having bleeding. And same can go with hypertension. Once you've hit a certain maternal factor or maternal clinical symptom of severe range pressures, you're racing the clock. Pressures are one thing. Lab values on top of bad pressures are a whole different ballgame. And so we're monitoring all of that. But the answer is that we want your family to be intact, from munchkin to mom to dad, so you can all go through the drama together, right? But in order to do that, sometimes we have to give recommendations that feel intense and they feel sudden and they feel severe. And especially when they say, but I felt so good during pregnancy. I know. And I love that for you. But your body has changed its mind. For better, for worse, your body has said, I'm so glad you feel great and your pelvic pain isn't so bad, but your blood pressure is through the roof and I need to come out. And there's nothing to do about it. You know, it's not that they ate the wrong food or they should have waited to get pregnant for 6 more months or anything like that, right? This is a pathophysiological reaction that some women have to pregnancy. And as long as we are super close to full term or full term, we have a baby.
Yeah, that really sums it up well. I was thinking about how I feel like people need to hear this over and over and over and over again, because there's so many factors that go into a healthy pregnancy, and we have the technology to be able to intervene when necessary. And thank goodness for that. And it isn't always what we wanted, but the outcome is what we want. We want the healthy baby. We want the healthy mom.
Right. And I think that now I'm not saying that bedside manner doesn't matter by any means.
Oh, it does.
Right. How you present a situation is key to success. But that being said, I totally understand. I mean, 37 weeks feels early, right? Even for the person who potentially is tired of being pregnant. The odds are family wasn't planning to come into town. Maybe the car seat isn't even purchased yet because they thought they had 2 to 3 more weeks, right? Heck, first time moms assume they're going past their due date. Right. So here we are taking this presumed expectation that they have set specific things in motion by and brushing it all away. Yeah. And it can feel very overwhelming to say, no, I'm sorry, but you need to be admitted and we need to work towards your birth now. And all they think is, but that wasn't the plan.
Right.
Oh, I know. We know it wasn't our plan either. If it makes you feel any better, it also wasn't my plan for my patients. But when there's no other choice, usually people come around, right? And again, it's that explanation of, you're right, your baby is okay. And I'm so glad your baby's okay. But I can't promise that you will be okay if you stay pregnant. And if you're not okay as the vessel, as the carrier of this munchkin, then by default, your munchkin's not okay.
Yeah. Your situation was the gestational hypertension. So you didn't have severe range. And so then once you got to full term, the recommendation was to deliver. So how did that go for you after having all of the experience with moms and delivery? What was your experience like?
It wasn't terrible, actually. I didn't mind an induction. Definitely the fact that I had given a what to expect on an induction spiel for the past 10 years of my life at this, was very helpful. But I will also say that I deeply respect the impatience. I definitely had that. As much as it is so fruitful to do what we call ripening stage of an induction, which feels so slow, it was necessary. But it does. You feel like you're just sitting there. That's really tough because it feels very clinical. You've also been told that this is necessary for safety. Why are we taking our time with it? So there's a whole mix of emotions, but that part wasn't terrible. I did do a cervical ripening balloon. I didn't mind it. I thought it was fine. At that point, I think it was either cervical ripening balloon and bounce on the ball and deal with some pressure, or potentially go another 6 to 18 hours, chill in before we started Pitocin. And that I could not mentally do that. I would take the pressure. So we did. So we got admitted late on a Wednesday evening. I was lucky enough to be about 1 centimeter. We started with ripening medication called Cytotec or misoprostol. And so I took that medicine by mouth, and then they used what we call a mechanical dilation or mechanical ripening device called a cervical ripening balloon that applies pressure to the cervix and helps soften it and open it with a little bit of that pressure, especially when baby's head is not really low in the pelvis yet, which is common for first-time moms. That what we call descent, or the head moving lower down, takes usually later in the process or the progress of labor for a first-time mom. And so that balloon applies that needed pressure to the cervix to kind of start to melt it open. I always talk about to my patients the cervix being like that soft mound of clay on a potter's wheel. Right. And so that soft clay, the idea is that with gentle pressure from your thumbs, it will open into a bowl or a plate. Right. The cervix is kind of the same thing. If you have super cold clay that's not warmed up yet, you're not going to be able to apply just gentle pressure and get it to mold into that opening. You have to work it first. And so similar to a cervix, we have to soften that cervix. We have to get it warmed up. We have to ripen it in order for when we start medication for contractions, which is Pitocin, synthetic oxytocin, that the cervix is ready. The cervix has done its job to start to soften so that as we apply kind of that pressure, we're putting pressure on the gas, we're starting to get your uterus working, the cervix is more agreeable to open and dilate. And so I did the cervical ripening, and then we started Pitocin, and then I was very nervous as a first-time mom, not necessarily actually about pain. I also had an excessive amount of fluid, which is normal with giant babies and potentially PCOS moms. And so I had a lot of fluid. And so I was very scared of having to go to the operating room after they broke my water, potentially an emergency, and having to go under general anesthesia. So even though I was not uncomfortable yet, I opted for an epidural at about 4 centimeters before they broke my water so that if something happened, I could stay awake during the surgery. So I got my epidural. It was excellent. Best choice. My husband and I were very thrilled with that part of the labor. They then broke my water, and basically from between Thursday at about 4 p.m. when they broke my water, I made pretty decent change. I did get an IUPC, which is a way to monitor contractions from the inside versus the outside of my abdomen to make sure that I had the right amount of Pitocin that I needed, a little bit more specific data collection to help with some unique care planning. And then I was obsessed. As a bedside nurse, Kelly's going to be very offended by this, but I was obsessed with making sure I got turned every hour. So I would set an alarm and I would hit my nurse call light. Please don't do that to anyone. I just have neuroses. Please don't be me. So I would set an alarm, and finally my husband and my bedside nurse, who were lovely, stole my phone, and she set her own alarm so that I wouldn't be waking the entire room up every hour on the hour to get rotated. So I was a big believer in my spinning babies and my movement with my peanut ball, especially after my colleague, who was my doctor at the time, said, "Oh, Munchkin feels asynclitic." Oh, and then I went off the rails. I was like, "Oh, every 45 minutes. Oh, nope, got to do it." So don't be like me. I promise it's fine. The nurses know what they're doing. Trust them. But I loved getting moved. I did all the positions, side to side, upright, the whole kit and caboodle. And then my provider checked me and she was like, "Okay, you're complete. You're like +1. This is great. You're going to start pushing. I'm going to go take a shower and then we'll deliver before 8 o'clock." And I said, "Awesome. Sounds great." So I brushed my teeth with my little spit bowl because, I can't move with my epidural. I'd be get ready. My mom and my sister are there. It's pre-COVID, obviously. We're very peaceful. I pushed twice and my nurse says, "You have to stop pushing." And my instinct goes, "Why? The baby's heart rate is fine." Because why else would anyone tell you to stop pushing? What's going on? And she goes, "You're going to have your baby without a provider in the room." And I was like, "But I am a provider." She was like, "No, not the same thing." And I was like, "Okay." So I got to sit there for another 15 minutes, just chilling as my child is crowning and I'm feeling nothing because there was no one in the room because my doctor was in the shower. Luckily, obviously didn't really care because it was fine. So yes, I had 2 colleagues in the room when I delivered because it was change of shift because of course it's 7:30 in the morning. So I had my night nurse, my day nurse, 2 docs, and it was great. I was very fortunate to only push for about 20 to 23 minutes, which is very unheard of as a first-time mother. Again, I don't know why I was lucky enough to do that. It makes me better that was not the case with the second one. And so, but it was great. And he came out screaming, crying, and he went straight to my chest. I had a very standard 2nd-degree laceration, which they repaired very nicely with my epidural intact. So I didn't feel anything but some gentle pressure, which was very nice. No abnormal bleeding. Went up to postpartum. He got a little, for anyone listening, in case you don't know, babies are kind of stupid. They're real cute, but they're real dumb. And so he decided to have some breathing issues. He decided to try holding his breath, which is kind of frowned upon. And so my postpartum nurse freaked out. So he got a chest x-ray. It was fine. So of course, Nikki was like, do some skin to skin. I was like, that's my plan. So we did skin to skin, and then he was totally fine. And we went home at 48 hours postpartum, and it was great. It was everything I wanted in the sense of I loved cuddling him. It was great. My family was amazing. It's a lot of work. I did not realize how much I didn't know, considering I had been so immersed in the birth world and the birth community for so long and had dedicated theoretically my career, my professional life to this. I felt very surprised by what I didn't know. And that probably was the biggest cause for my postpartum depression. I didn't know what I would need. And I thought I did. I thought it was just some support here and there and just cuddles and time away from work. And I'm too extroverted for that. So I actually needed more visits, and not, again, I didn't need them to hold the baby, but I needed people time. I needed people physically in my line of sight. And with paternity leave, as short as it is, that wasn't really a thing. And so I was quick to realize how lonely I was. And so once we figured that out, it got way better, but took hitting some rock bottom there. There's only so much reality TV you can watch before you are probably close to clinically insane. And so got into counseling, made better arrangements with friends and colleagues and my family to have somebody pretty much there. And again, it wasn't that I needed someone to hold the baby. I just needed someone to interact with me as an adult. And so, I learned even more about myself for sure, but no postpartum complications after that. With Sammy, on the other hand, I had some early bleeding, very much convinced myself while working, may I add, had bleeding while I was on call. Definitely believed I was miscarrying. I was frantic. I was on with a colleague of mine, and I was like, you have to sono me. She was like, there's nothing I'm going to be able to see. You are 6 weeks pregnant. And I was like, you have to sono me. You have to tell me what's going on, which of course resulted in no information, because as it should, but freaked out, had convinced myself and my village that this had not been successful. And, we were going to have to make arrangements for another transfer and, all this stuff. So kind of trudged my way at about 7 weeks to my scheduled appointment with my infertility provider, and was like, listen, I had a ton of bleeding. It lasted for like 2 days. I know what you're going to find. They were like, oh my gosh, you should have called. We're so sorry. Let's just, confirm that there's nothing left in the uterus. I was like, of course. There was heart tones. So here we are. Yep. I did a lot of swearing that day, as did my provider, because we were both very shocked. It was great, but yes, that was really good thing I did my Lexapro that day. That was very strange. And my first lesson in no pregnancy is the same, right? I say it so I'm blue in the face with my patients, and yet I needed to apparently learn that lesson firsthand. So already starting very different with Sammy, and because of my PCOS and my body mass index, there's a recommendation for an early glucose screening to make sure that I don't have either type 2 diabetes or what we call pre-gestational diabetes. Did great, rocked it, super excited, feel like we're doing great. Gloriously failed my 28-week blood sugar test. Was immediately diagnosed with gestational diabetes. Didn't even have to do a 3-hour, just really went for it. And that's not uncommon. One of the symptoms or part of the metabolic triad with someone who has polycystic ovarian syndrome or PCOS is something called insulin resistance. This is where your pancreas works. You make insulin. It's that your cells don't necessarily have the most intense response to insulin. So insulin is supposed to be a little bit like a lock and key. Insulin is supposed to talk to the cell, open the cell up so that sugar from the bloodstream can go into a cell so the cell can utilize it to carry out its cellular functions. Well, with women who have PCOS, we have something called insulin resistance. It's like there's something where the key doesn't fit into the cell lock every time, or as often or as routinely as we want it to. So more sugar stays in our bloodstream for longer, therefore potentially increasing our risk for adipose tissue or fat or a larger BMI. But it also makes it much more common for us to have gestational diabetes in pregnancy because it's basically our natural state. Our natural state of insulin resistance is on some level diabetes. And so it wasn't surprising, but was definitely different. I started with oral medication that didn't do a lot. So went to insulin pretty quickly and needed a hefty amount of it to keep things under control, even with strict diet and exercise guidelines, measuring my food, the whole thing, which was definitely different. I only needed injections in my first pregnancy to get pregnant. I definitely didn't need them any other time. So back on injections was fine, but different, especially having a 4-year-old who's like, Mom, why are you giving yourself a shot? Let's have that conversation 900 times. Thank God they're so curious. Yeah. And so we would have to teach Nate like every day, this is mommy's medicine. No, you don't need a shot. It was on replay. But part of that definitely led to some concerns for Sammy. Gestational diabetes, when you're on medication, the recommendation is to consider an induction of labor between 38 and 39 weeks. And that's because at some point, we do worry about not only fetal size, but the other is that there's risk to maternal and fetal cardiovascular systems when you're on that type of medication, right? At some point, there's a risk that it stops working really well. And the more high blood sugars you have, the more likely you are to potentially have vascular damage from the pregnant woman's side, as well as potentially that sugar passing through the placenta to Munchkin's veins and arteries and also potentially causing damage or trauma there. So I knew that going into it. And I thought, okay, well, I'll be a couple extra days pregnant. And then blood pressure went up again. Sure, not surprising. We'll argue it was stress this time. We'll say it wasn't pregnancy, my own mental health. This time was a little bit different with Sammy. The pressure started mild range. So for gestational hypertension, same kind of criteria. Blood pressures, a couple hours apart, meeting criteria, no problem. We kind of knew that this was coming. So we just kind of moved the date up a couple of days in order to have an induction date. My village was ready. We knew this was happening. So Nate got to go hang out with grandma and grandpa, and my husband and I got admitted. While in labor, my pressures did hit some severe range. I did not necessarily need IV hypertension medication, but I did need oral hypertension medication. And I did continue it for a month postpartum as my blood pressures remained elevated. Nothing about that is abnormal. Unfortunate, only because, again, just feels like a lot, but that is pretty common with hypertension of pregnancy, just because, yes, the cure is delivery. That doesn't mean that your body suddenly doesn't know that it wasn't just pregnant. And so it's those pregnancy hormones and all of that that can still persist and perpetuate those elevated blood pressures. So nothing totally out of the ordinary. The next biggest thing I learned, though, with Sammy was that gestational diabetes, especially when you have abnormal fastings, which is the first blood sugar you take in the morning after not eating anything, when those are consistently high, it can decrease the amount of surfactant, which is kind of like a lung goo that your body makes, that we all have, that babies need to make in order to help their lungs inflate and have that oxygenation exchange, right? So in the bronchi, in the alveoli, which are the branches of the vessels inside of our lungs, that's where oxygen is exchanged from the lungs into the blood and then carried to the organs. And so that surfactant helps with that process. And in a pregnancy, in a growing baby, the surfactant and Munchkin's insulin are actually made by the same pathway. And so if a baby has to start potentially making its own insulin prior to delivery, its ability to make surfactant or enough of surfactant can be jeopardized or diminished. So that's what happened to Sammy. So we delivered at 37 and a half weeks, vaginal delivery, another induction, slower than I would have expected as a second-time mom, but I'll tell that story. But Sammy ended up going to the NICU. He initially just needed some observation in the nursery. I was taking a pretty decent nap, and I got a knock on my door from a colleague saying that the NICU provider wanted to talk to me, and lovely, lovely man. I work with him as a nurse midwife, knew him well. And he says, hey, and I thought, biscuits. Okay. And I said, hey, yourself. And he says, so remember how we made that joke that like you wouldn't need to see me after the baby was out because you'd be full term? I said, sure do. And he said, I'm admitting your baby. And I said, okay. And so Sammy went upstairs to join the NICU crew. He was on nasal cannula oxygen. He got a nasogastric tube for a couple of feeds because he needed so much oxygen. He was there for a total of 5 days, 2.5 days of intervention, 2.5 days of no intervention to just pass all the quote unquote tests based on their protocols. And then he finally got to come home and has been amazing ever since. But I definitely didn't expect that, especially considering he was smaller than his brother. We felt like we had controlled everything else. We did not expect a respiratory transition concern, but very grateful that there was a NICU with our hospital planned birth to alleviate those concerns in the safest, best way possible. For Sammy's induction, I was similar. I was at 1. And so again, we started with Cytotec. My blood pressures were not severe range at this point. My lab values were normal. So we felt like we had the time. So we started with Cytotec. I ended up getting 2 doses. Yes, of course, opted for the cervical ripening balloon again. I took the pressure and moved on. And then similarly got on Pitocin, had my water broken, and with time and effort got to 10 centimeters. It wasn't necessarily that it was much slower, but it definitely felt slower. For whatever reason, this time around, my epidural didn't work. And so I got an epidural at about 4 centimeters prior to my water being broken. And I thought I felt pretty good. But then they broke my water and placed my bladder catheter and I felt it all and I just kind of ignored it. I just thought, it just maybe hasn't set in right. Haven't had enough time since they placed it. But as I started to dilate more and contractions came on, it really wasn't covering it. So we tried giving one more medicine. That didn't work. We tried replacing it. That worked a little bit. And so ultimately, by the time it wasn't necessarily abdomen or back pain, but it was very pelvic and hip pain, and definitely felt the pressure to push, the burning ring of fire, lots of tears between myself and my partner, just because it was so different. With Nate, I really truly felt nothing. Pushing was such this blasé experience. The whole thing was blasé. I really was like, you could probably cut me open and I wouldn't feel anything. Okay. And Sammy was definitely not like that. There was significant discomfort that led to just fatigue and processing difficulties, right? It was really hard to regulate myself, pep talk myself up for 2 reasons. One is it hadn't been my plan. My plan was not to experience an unmedicated labor course. And my previous experience was just so different. I only had 1 experience with anesthesia. It was so excellent that anything but that I wasn't mentally prepared for. Luckily, all is well that ends well. Pushed very efficiently, yelled at my provider after delivering him, thought I might get fired because of the things I said to her. Luckily,
not her.
Not the
She's
case.
not the one that's going to be upset about that.
Nope. She laughed it off like the gem that she is, the treasure. But yes, yelled at her very strongly. Yep. One of the excellent night nurses yelled at her, screamed at her. She got in my face and told me to calm down, which was very helpful and necessary. So really good colleague bonding right there. Really, it was great. But no, I mean, all in all, in terms of, in the grand scheme of things, as my husband is probably listening, can hear, I couldn't reproduce the pain if I wanted to. I couldn't. I can talk about the emotions for sure. I remember how strenuous it felt and feeling and turning to my partner for support, even though he is, as I am well aware, working in the community, he can't do much for me, right? And so even though he was so willing and graciously to accept that burden that I was trying to put on him, he felt just as helpless as I did. And so although we both felt safe in the encounter, it was processing those emotions. I can feel those. I remember those moments. But I couldn't tell you what the pain was like. I couldn't describe it now. I have no idea, and that is good, I think.
The halo effect.
Right. I mean, I remembered on some level in the sense that I remember I couldn't stop, right? I had to push. I needed it to end. But there's nothing I could do right now that I feel like I could reproduce that same intensity.
I feel like when I stub my toe, it gets close.
Yeah. There are certain things you're like, oh yeah.
Or like I have like severe diarrhea and a stub toe at the same time.
Yes. So that is still true.
Yeah.
Oh yeah. Gastric upset is probably as close as you're going to get. Mm-hmm. Yeah.
But the bone pain for me is like a stubbed toe, but you can't make it stop.
Yeah. But the rectal awareness, Yes, there is only gastric upset really does put you right back in it.
Right.
Because it is sometimes that intense and that unforgiving. But, you know, again, in that sense, all went very well. I was very comfortable with the management plan. I was comfortable with the induction plan. For better or for worse, I knew what I was getting myself into. Even if the epidural was not working, was not part of the plan or things I had prepped for mentally. I had prepped for the cervical ripening balloon. I had prepped for exams. I had prepped for artificial rupture of membranes or an amniotomy, which is where the provider breaks your water. I had mentally prepped for all that. I had coached my husband through all of those expectations, you know, so that part had certainly helped. Now, part of it's because it's what I do for a living. The other is even he had some experience, right? I mean, roughly the same type of scale happened with our first. So even though sure. Did I wish it had gone faster? Yes, but it wasn't terrible.
So you said that pushing was different with both.
Mm-hmm.
And I hear you coach people all the time in pushing. So did you practice what you preach?
Actually, yes, I really did on some level. My husband always says, not with the Sammy, but with the first one, his biggest takeaway of almost like shock and awe, other than like birth as a general all-encompassing thing, was how quiet I was with pushing. He was really surprised. And part of that was because all he's seen is some made in Hollywood movie about a woman screaming as she births a baby, right? But he also just didn't realize the type of like inner focus that it can take. And so I did. I said to myself with pushing with Nate, I said, okay, what would you tell a patient? Okay, so you would go into this position, you would try and relax your face, you would try and take all that energy, even if you can't feel where you're pushing it, you would visualize abstractly, forcing that energy into your bottom, right? And being pregnant, constipation, very common side effect, right? Very, very common complaint. I put myself back there. I said, okay, the last time you were constipated, sitting on a toilet, trying to have a bowel movement, what did that feel like? Where were you pushing that energy towards? And I did. I kind of talked myself through it. And I tried in that sense. Even though I know there were certain recommendations made because I remember hearing them, whether or not I took their recommendations, I don't know. I think I was so focused on being like, okay, this is what you would tell a patient. Does this work? And partly was for my own kind of science experiment. Is what I'm saying to a patient even remotely relatable or successful? And the other was, well, at least I've done enough deliveries where I said it over and over again. Something clearly works. So let me at least try my own advice and see if it works. And it did. I mean, there is with or without an epidural, the vaginal canal there, you know, and ultimately when we're talking about birth, the birth canal, the nerves are not placed super great, right? So there's nerve innervation deeper into more the, like what feels like rectal tissue or very like low posterior vaginal canal, so towards your spine. And then there's nerve endings around the labia and at the clitoral hood, right? And those are for multiple reasons. One is survival instinct, right? You need to know when you have to have a bowel movement. That's how you excrete waste. You can't keep your waste inside your body or you get sick, right? So you have to have something that triggers your body to tell you to release the waste or have a bowel movement. For labia and clitoral hood, part of it is safety, right? You want to know when something is getting near a vulnerable part of you, right? Mucous membranes, obviously in a social context, a different, argument of awareness and vulnerability. And also for those of us in a consensual relationship that is looking for pleasure from sexual intercourse, having some nerve endings in that area is also helpful. But otherwise, the rest of the canal is not awesome for any of that, much to the dismay of providers and potentially women of all ages in a consensual relationship. It doesn't do a whole lot. And so sometimes until the baby is low enough in the birth canal to innervate or push on those nerves that innervate more of the rectal tissue or the posterior vaginal canal, or right as baby's head is starting to stretch open the labia and potentially push pressure against the clitoral hood, a lot of it is guesswork, right? And none of us, ideally, have pushed something out of our vagina. Granted, right? Like, ideally, that's the idea, right? Even if it's experimenting, right? Those of us who use tampons or Diva cups, no one's trying to expel something from there, right? However, on a regular basis, we're attempting to expel something from our butt. So the encouragement is push into your butt. And it's not inspirational and it's not pretty and it's not kind. And there are so many other kind things I say to patients about how they're amazing and their birth story and this, that, and the other. And Then we get to that point. I'm like, oh, by the way, we're going to meet your kid, but push into your butt. Yay. But it does work, amazingly enough. It does work. And that's what I did. I tried to keep my face as relaxed as I could, took my big deep breath, held my breath deep in my lungs, trying to use that as my powerhouse, my power source, and just focused on if I were trying to have a bowel movement, what would my body be doing to push? Even if I couldn't feel it, where would my energy be going? Right? When patients say it all the time, they're like, I don't feel like I'm doing anything. And I'm like, no, I promise you're doing all the right things. And so it really can be that abstract, but that's successful. Now, pushing with Sam is a little bit different. I very much knew when I was 10 centimeters. I had kind of gotten a little bit of extra medication in my epidural that had kept me a little bit comfortable from 8 to 10 centimeters, especially in a sitting up position versus a lying down position. And I remember looking at my nurse, Kirsten, and I said, if I am not 10 centimeters, we are going to the operating room. I'm done. Luckily, I was 10. Excellent. And that's because the pressure was very suddenly overwhelming. I had gone from being like, okay, I can breathe or wiggle through this to, I don't know if I can stay sitting, even though I'm not actually able to move my legs. And so there was a very much that sudden gastric upset feeling like, oh, I need to wiggle in hopes that I get to a bathroom soon. So that helped. That immediately gave me a sense of awareness. It immediately gave me a sense of direction to encourage or to help lead me and where I'm going to apply my energy and my force. The other thing that happened was we being complete and being uncomfortable very quickly got me into the pushing position. I felt most successful and most strong lying flat on my back. That's a me thing. I enjoyed the idea of kind of like that row machine pulling back equally on my knees. Not everybody feels that way. When I talk to my patients about pushing, I ask, where do you feel the strongest? Where do you feel like you mentally and emotionally had the most success in your pushing? And if that's on your side, hands and knees, flat on your back, whatever that may be, that's what I'm going for. Because again, if it is that abstract kind of discussion, regardless of my sensation, if your effort is going to be better because you feel successful, then we're going to utilize that emotion and push through it. And so for me personally, I felt most successful on my back. So they got me into that position. And as soon as we pulled my knees back, I started heaving, sobbing. It was the most intense pain I've ever felt in my entire life. And I couldn't do it. And I was like, oh, nope, I need a vacuum. I can't do this. And so then we tried again because I was like, nope, I can pep myself up. Just kidding. I can do this. Couldn't do it. She was like, okay, you're done. You're getting an epidural bolus. I was like, I just had one 2 hours ago. She goes, I don't really care. We're doing this again. I was like, okay. So I got a little bolus, gave it about 15 to 20 minutes, pulled my legs back. And although it was intense, I could easily pep talk myself through it. I could harness it. It was no different than just like a really nasty workout. You're just trying to push that last hill or those last crunches or whatever. I could find enough of a personal pep voice to go through it. And pushing was efficient, thank God. But that direction was just more intense. And it was different because the awareness was just so much more that even though they were counting and coaching me and encouraging me, I definitely, not in a bad way, but didn't need it because I was very aware. Like I knew exactly how close I was. I knew how much of his head was out. And part of that is because after one child and working in the field, there's a certain awareness that I expected, like, oh, if I'm going to have pain, this must be what correlates with what. And it was quite obvious when we went from, okay, still completely inside the vaginal canal to, oh, probably almost to eyebrows to, okay, the head and the shoulders are out, because it just all felt very different. And so in that sense, those phrases and terms that you hear are out there, right? So you feel pressure, you feel that almost spontaneous urge to give in to that pressure. Again, kind of that gastric distress, kind of almost having the poop sweats, I had a mentor once call it, where you're starting to shake and wiggle if you don't get to a bathroom, to a very intense almost burn. So the idea of almost that skin stretching to accommodate the head, being just, those nerve endings are just so friable in that sensitive tissue. And then such this overwhelming relief as the largest part of him, his head, kind of came through. And even with the shoulders, again, still needed to give a push. There was just doesn't push all, like the circular part, right? So the head pushes on every nerve ending all evenly. The shoulders only push in like 2 places. So it's much easier. And again, I didn't actually have any pain. They didn't have to give me local lidocaine for my very small repairs. So I'm not sure why there was just this one section of my pelvis that didn't seem to get that anesthetic relief that we had hoped for. But again, I only pushed for about 9 to 11 minutes, thank goodness, which can be normal for a second-time mom. So it wasn't totally surprising, but I was very ready to be done. And again, that part was different, although I still, same idea of push into, give force towards your bottom. But instead of kind of this abstract mental picture that I was building for myself inside my head with my pep talk, I had physical factors that definitely triggered and helped with that direction very efficiently.
So everything after the birth was pretty straightforward, right? He reacted, cried, didn't have to go to the NICU.
Yeah. So he didn't cry right away. Yeah. So Nate did. Nate cried great.
Right.
Sammy didn't cry right away, which we were not totally surprised with. His Apgars, I think, were 5 and 8, but I was on Lexapro my whole pregnancy. And so we weren't totally shocked that he maybe was a little bit respiratory lazy. He did pink up. We didn't call NICU or the pediatrician team to the bedside right away. It was at a half an hour of life. We both felt he was a little grunty. They came and assessed him, cleared him. And then actually right before we went up to postpartum, the pediatrician, that group that we see, did rounds, again, cleared him, went up to postpartum. And at this point, I've done skin to skin, which I didn't really do well with Nate. I was all too happy to have dads, just my, aunt now and grandma now, to hold him. And so I didn't necessarily do a ton of skin to skin with Nate right away. And so I was really, really adamant about doing skin to skin with Sammy. And so I had been doing skin to skin basically for almost 2 hours straight, other than some assessments here and there. And so we got up to postpartum and we decided that Sammy was going to go to the nursery. I was going to take a nap and Danny was going to head home for a nap and a shower. And it was while he was in the nursery, he spontaneously desatted and they got some gunkies out of him, right? Got some amniotic fluid. He didn't get a good squeeze. There's only 9 to 11 minutes of pushing. So again, normal. They thought he was okay. But obviously after he desatted spontaneously, he had to stay in the nursery for, I think, 4 hours is what our NICU neonatologist was going to give him. And within the not even a full 4 hours, he had spontaneously desatted. So they said, no. So I got to snuggle him for about 5 to 10 more minutes before they took him to admit him to his new hotel in the NICU. And again, I had no idea until the neonatologist sat down and kind of talked to me about his theory for why Sammy didn't transition very well. I had no idea that they were of similar pathway for fetal development. So that was crazy amazing to learn and helped certainly my patient care on a whole different level. And although NICU was kind of scary, first and foremost, they're amazing. I got way more sleep than I would have expected, which was kind of nice. And they don't mess around up there. Those nurses they run a tough ship. And you know what? Good. Babies need to learn a thing or two. And so they get those babies right. Those babies are good with sounds and lights and beeps, and they'll sleep through anything. They don't care how many times you change their diaper. Again, they'll sleep through anything. They get them on a feeding schedule for you. They literally like, how often would you like to feed your baby? And I was like, well, I have formula feeding. I am not somebody with PCOS who does breastfeeding. I am not a great candidate for that. And it does not help my mental health. And they're like, okay. So like 8, 12, 4 and 12. And I was like, yeah, sure. No, that's what he was on when he came home. And I was like, this is great. It's the best thing ever. This is awesome. I felt like I didn't know how to increase feeds with Nate. It was a big learning curve for me, considering breastfeeding is the majority of the information you get. Formula feeding is not always discussed as well as it maybe should be. And so I didn't really know how to do it. And it was really a trigger for me thinking about Sammy's growth and development. And then I didn't have to worry about it. NICU just did it. It was great. So although I'm not saying that everyone should encourage to have a NICU baby, it was great.
That's awesome. Yeah. That's kind of how I thought that life was going to be, because I'd been postpartum nurse on a not baby-friendly unit when my daughter was born. And so I was just really expecting things to be on schedule immediately. But nope, that's not how it happened with my first either. So you did mention something that kind of came up for me when you're talking about how the surfactant and was it the blood sugar to the insulin resistant, that they were kind of made by the same?
Yeah. So I guess, in fetal development, the baby ideally doesn't start to make their own insulin until out of the body, right? Or out of mom, I should say, right? As their own person, because it has to, right?
Yeah.
And so because it's now doing all the things on its own. And it's not that it doesn't make insulin. It just makes a very small amount. It's that the priority is almost like 80-20. So 80% of this pathway is supposed to make surfactant and 20% insulin until certain triggers happen, extrauterine life. But when you have fastings that are uncontrolled, and so they're elevated, right? That means that the longest duration of time where you're not checking your blood sugar, which is overnight, is most likely also elevated. So here you now have no exercise to lower it, potentially even your liver is continuing to try and make sugar because it doesn't know any better, right? Because that's what your liver does at night to try and keep you alive, is feed you because you're not feeding yourself. So here you have this potentially 10 to 12 hour period where you have elevated blood sugars, and that sugar is crossing the placenta. And baby's body, that pathway gets triggered because it feels like suddenly it's supposed to be doing something based on physiological changes of that influx of sugar sooner than it's supposed to. So suddenly that pathway becomes maybe 50-50, 50% insulin and 50% surfactant. But that change in that decreased formation or decreased amount of formed surfactant can impact lung maturity long term. So the way it was explained to me was that even though Sammy was 37 weeks in a couple of days, his lungs were maybe closer to like 35 and a half weeks.
That's interesting to me because what came up for me when you were telling me about that was like, oh, she's going to have to get betamethasone. But then I was like, wait a minute, she's diabetic. So, and the diabetes is causing this. So then like the betamethasone can increase the blood sugar. And then so obviously that wouldn't help.
So not only would it, yeah. And the other was that at the point where you don't know till you know, and not in a bad way, but there's always a chance that even with this potential pathway changing in its percentage of successfully created surfactant versus insulin, until Munchkin comes out, even if you know it's a risk, it doesn't necessarily mean a transition issue, right? That's like being able to forecast whether every 36 weeker is going to need a NICU admission versus a 41 weeker. And we know that's not true. There are plenty of 36 weekers that kick butt, and there are 41 weekers that need extra support. And so even if there was concerns, there's no clinical advice or clinical data to support getting either surfactant or betamethasone during pregnancy, because until you see that it's an issue, it's not an issue.
Yeah, that makes sense. The other thing I was going to ask you about was you had mentioned with your first pregnancy that you had extra amniotic fluid and you were concerned about them breaking your water, so you got the epidural. I know why you did that, but
you really want me to say those big scared words, don't you?
I do. I want people to understand because we don't know what we don't know. And so, yeah.
All right. So I will do that for you. I assumed you were not going to want me to say it. So there is, although ideally a low risk, there is a risk, whether even in spontaneous breaking of water, but usually more specifically when there's what we call artificial rupture of membranes, or where the provider, while in a labor course or in a hospital situation, breaks the bag of waters, breaks the membranes of water. There's many reasons that this is clinically recommended. Usually it's an augmentative intervention. So the idea is that it's going to progress the labor course. The idea is that it's pushing you closer and closer towards delivery. So with Nate, in hindsight, being 2020, we assume I had gestational diabetes with him. I just so happened to pass the test. Like I just got lucky that day, because between PCOS, insulin resistance, and most likely undiagnosed gestational diabetes, extra fluid or polyhydramnios is very common. It's sometimes what we see when we're, could there have been some gestational diabetes and we missed it? And so that extra fluid, the concern is that when they break the bag of water, there's always a chance that in a river rafting type experience, with that big flow, that big gush, that forceful release of this pent up fluid, that it may pull something like the umbilical cord with it. So the umbilical cord is floating around in there, right? For better or for worse. Baby's tangled up in it, baby's not. It's a plaything. They just coexist. But when the water comes, if the cord were to flow with it, almost like a pebble or a leaf in a stream, if the cord comes forward in front of the baby's head, and then as that fluid drains, baby's head settles down against the cord, now the cord is trapped. And that's what we call a cord prolapse, right? Prolapse being that has fallen out or in front of something, and the cord being the umbilical cord. We don't want pressure on the umbilical cord. The umbilical cord is the pathway by which the placenta and mom communicate to baby their oxygenation needs, their nutrition needs. So if we have basically what's become a tourniquet, right? You have baby's head slowing blood flow through the umbilical cord, therefore slowing the deliverance of oxygen to Munchkin. Well, Munchkin's not going to love that. It is considered an obstetrical emergency. There is no way to dislodge baby's head and push it back up. That is not a thing that we can do. And so usually the recommendation is an emergency C-section. And the reason we say emergency is because obviously the longer baby goes without oxygen, the more likely there is for risk. Now, are there things we would do in that moment if found clinically to reduce the risk of baby truly getting no oxygen while we got baby out? Of course. Usually these things are found very quickly. Babies do great. Doesn't mean it's not scary and intense, but babies usually do fine. And so I was very fearful of this. And knowing that it was a risk, even if a small risk, I wanted to make sure that if I had an epidural, I would be able to be awake for an emergency C-section and not put under general anesthesia. Because if you have a cord prolapse, you can't sit up for an epidural because you're just applying more pressure to the cord. So I wouldn't have been able to sit up and get an epidural. So I would have had to stay lying down, potentially with my hips elevated to try and let gravity pull the baby's head back from the cord, things of that nature. And so that's why I did it. So I mainly was doing it out of, even if there was a low risk, any risk, I wanted to try and prioritize certain outcomes, right? And it wasn't even that I was against breaking my water with that risk knowledge, right? I agreed with breaking my water as a step towards progress. I agreed with the intervention. It was more that knowing this intervention was needed and being okay with it. If there is an outcome that's unfavorable, how do I maximize the goodness of that outcome? Right. And for me, that was being awake. And so I wanted to eliminate a certain risk of not being able to be awake.
Yeah. And it's easier to do interventions when you have an epidural too, just because you're not going to be fighting us. So
not just you don't care if my hand's in your vagina for a long time. Yeah.
Yeah. That it does.
Guess what, friend? That's what the intervention is my hand goes in your vagina and I push the head up.
Yeah.
Super
Until
lovely.
It can come
real
out
cool.
the sunroof.
We got real close. That's great. We got real close, real fast. A lot of good times right there.
In the weirdest way.
Yeah. I'm like sitting on them. Yeah. Great. Mm-hmm. We ride in the bed to the OR together.
Yeah. So fun.
Yeah.
The last thing that I wanted to ask you is if you could go back and talk to Michelle at any point in this process or prior to this process to tell you things that you wish you would have known, what would you tell Michelle?
So probably twofold. So the first one is I would probably not wish for it to be over as soon. Don't get me wrong. I'm so glad I didn't go to 39 weeks pregnant. I was not a nice pregnant human. Like, I love being a mom, but I was not a nice pregnant human. Like, I just wasn't. And so I'm sure all of my family and friends were very glad that I was induced. But I also, because I wasn't the nicest pregnant human, not so much with Sammy, but with Nate, I just felt that I just had to get to the finish line. Like I had to do it. I just had to get there. I just had to have this baby in my arms. Now, part of it was my infertility journey. I was ready for this prize. I was ready for this safe outcome. I was ready for this thing that I had been fighting for and climbing these mountains for 2+ years. But I also felt like I rushed it. I felt like because I was a provider and I was rushing it, I didn't necessarily enjoy prenatal care. I didn't enjoy the ultrasounds as much as maybe I should. I didn't do a prenatal massage. I really enjoyed my baby shower, but again, it just felt like it was this thing to cross off the bucket list. And so I kind of wish that I had mentally slowed down maybe a little bit during my first pregnancy. I definitely did that on my second, and I enjoyed it more a little bit. Don't get me wrong, I was still a cranky pregnant woman, but I at least slowed down. I slowed down a little. I mean, I got a massage regularly. I saw a chiropractor, and, I obsessed over the pictures and the ultrasounds. And, I went to my prenatal visits and I asked questions, even though I didn't really need to. And, I don't know, kind of faked it till I made it, which was a little bit nicer. The other is actually less about labor and delivery, and not because I know about labor and delivery or anything going into it. I had scheduled a C-section with Nate because he was trending so large that I was like, you know what? If we go to 39.5 weeks, I'm not even playing this game. I'm having an elective C-section for giant baby. I'm not risking this. I want to save my vagina. I don't want anything to get stuck or injured. No, we're done. And then when I had to be delivered because of clinical changes in my blood pressure early, we decided to give it a shot because that was more average, right? And he was still 8 pounds, 6 ounces. He was not cheap or thin at 37 weeks by any means. But I really wish that someone had said to me, Michelle, nobody talks about formula feeding. I was so open from the get-go with my providers, with my colleagues, with my village, that I was formula feeding. Like I was like, please do not send lactation into my room. I don't want to hear it. It's a waste of their time. They have way more important patients to see than me. Like they do not have to write a note on me. Please just don't even make it a thing, right? I had decided before 20 weeks with Nate that I wasn't doing it. Between my PCOS and what I thought I was going to need mental health wise, I just couldn't do it. I needed to be able to allow my village to care for my son in times of feeding as well. But I wish someone had said to me, like, they're not going to know how to teach you. They are so focused on breastfeeding. We got home from the hospital at, 48, 49 hours post-delivery. And no one had told us to increase the amount we were giving him. We were still giving him less than a fluid ounce because that's what they told us to give him. And so that's what we were giving him. And so he was screaming every 20 to 30 minutes because he should have been at 2 to 3 ounces every feed at that point. And, if you ask someone in hindsight, they're like, well, of course, why wouldn't you? That's what but I'm like, great, but that's because now this is 5 years later and there's this movement and there's all these new discussions and social media posts and influences and people who have taken it upon themselves to make discussion of motherhood easier or at least more realistic since COVID happened, because I think finally moms are like, oh, look it. We have time because you're home and you can watch children and I can go about Sphinx. But I wish someone had said to me, do some research, because ultimately I did none. I just assumed that I would get some sort of sheet or catalog or something that said like, hey, this is what you increase, right? Because if you ask somebody in breastfeeding, they're like, of course you increase it by 5 to 10 minutes every side, every feed, right? Like, and they have all these instructions and you're like, okay, and now with formula. And they have like nothing. And in your discharge paperwork that they like give to every patient that is sponsored by the hospital, it's a 4-cent blurb and there's 8 pages on breastfeeding. And you're like, I know nothing. And so I wish there had been more advocation or empowerment from my village or from myself to say, just Google it, right? Whether it's Mayo Clinic, whether heck, you go to Similac.com because there's a whole website about how to formula feed and how to pick which formula and how much they should be eating and how to store it. And I had to do so much research in the first 48 hours being home that I swear I could write a dissertation now. And so I wish in that sense, because I really think that was just one cornerstone that I really feel, for whatever reason, feeding with my son, with my first son, became such a chore emotionally and physically that I really feel like it was one of the major triggers for my postpartum depression. And so that's why I said I knew it was going to be a trigger for Sammy. And so the fact that the NICU took so much of that off my plate just by happenstance was such an incredible relief, because even with all the research I had done, with all the forms I had printed, with all the laminated papers and posters I had all over my house ready to do this, I was still nervous about it, because you're basically told, here's a baby, love it, feed it, and change it. And I felt like I couldn't do one of those 3 things. I didn't know how to feed my first baby. So I was so worried about it with my second. And so that's the one thing that I wish someone had said to me, was like, listen, I don't care what you're going to do, but if you're going to do this route, here's one option. If you're going to do this route, here's one option. Hopefully this takes you for the first 7 to 10 days of newbornhood until you can get your head on right and figure out what you actually want to do. And so that's what I wish.
Yeah. And I think that that's one of the most common causes of postpartum depression, is not knowing how to feed your baby, whether it's formula or breastfeeding, because it's hard. But
yeah. Well, and it's hard. And it's, again, literally, it's one of 2 things you're supposed to do, right? You're supposed to love it and feed it. Literally, that's it.
Yeah.
And even on some level, love can mean 100 different things to you and your family, right? Yeah. It's basically give it shelter and feed it. Mm-hmm. And suddenly you feel like you can't do one of those 2 critical survival things. Yeah. It's a little bit of a
little stressful.
It can torment you. Yeah. Yeah. Mm-hmm.
Yeah. Was there anything else that you wanted to talk about?
My 2 hours of podcast? No, I think overall labor and delivery, part of my clinical changes, my practice changes as a provider, now that I have experienced birth and postpartum depression and the ups and downs and everything in between, the gray area of pregnancy and, motherhood, I would say that for better, for worse, in all of it, try and be flexible. I'm not saying don't have preferences. I'm not even saying don't have priorities, right? Again, Feeding was a big one for me, formula feeding, making sure that I had to build, certain parts of my village. My priority with my second was having a really nice stroller because I wanted to be more active in my second postpartum course. And I just didn't like my stroller in the first one. I mean, I get having priorities and making those priorities come to fruition, but for better or for worse, something will go wrong. And wrong is not necessarily mean dangerous or a bad outcome. It just means something will not go the way you expected. Whether that's that you get peed on, pooped on, whether it's a NICU admission, whether it's a C-section versus vaginal, whether it's timing of delivery, whether it's breast versus bottle, whether it's boy versus girl, whether it's whatever, something will not go according to your planned or expectations. And so allow yourself some grace. You are allowed to have emotions about something going wrong. You can be super bummed and disappointed that you're getting a C-section, but so thrilled that your baby is healthy. It is okay to exist in a dichotomy of emotions. And that is not something that we tell moms or women enough. It is okay to live in a place where you feel both evenly. You can feel frustration and joy. You can be so excited that you're a mom and still super frustrated that breastfeeding is not going well.
Yeah. There's a Daniel Tiger episode about that. Two feelings at the same time. I think everybody needs
No, you can. Everybody needs to see it because it is okay to cry that breastfeeding is hard or that you now have to formula feed instead of breastfeed, but excited that you figured it out, right? You can be thrilled that your baby's gaining weight, but really upset that your baby's not sleeping, right? I mean, all of these things are normal and you don't just have to feel joy. You're allowed to feel both strongly and discuss both and articulate and vocalize both. And you should be celebrated for feeling whatever you feel.
Yeah. Yeah. Have your feelings.
Yeah. That's my takeaway. Have your feelings.
Love it. Michelle, thank you so much. I always learn so much when I listen to you. I love the way that you describe things.
Thanks.
All right. Well,
between have your feelings and gastric distress,
yes,
should be a good one. Should be a good one. Should be fine.
Definitely.
Thank you so much for tuning into my podcast. If you enjoyed what you heard, make sure you hit that subscribe button so you don't miss out on future episodes. Don't forget to share the podcast with a friend who can benefit from the valuable insights that we share here. And if you could take a moment to leave a 5-star rating and review, it would mean the world to me. If you're ready to work one-on-one with me to embark on a transformational journey towards a confident and empowered hospital birth experience, go to kellyhoff.com/empowered and enroll in my Empowered Hospital Birth Coaching Program. Together, we'll create a roadmap to a birth experience that you'll cherish forever. That's KELLYHOF.com/empowered. Let's make your birth experience extraordinary.